In the management of systemic sclerosis, scleroderma, traditional synthetic disease-modifying antirheumatic drugs, TSDMARDs, play a variable role, mainly depending on the type and severity of the disease. Unlike in rheumatoid arthritis, where TSDMARDs are more established, their use in scleroderma is more limited and often adjunctive due to the complex nature of the disease. Here are some TSDMARDs used in scleroderma management. 1. Methotrexate. Use. Methotrexate is often used for patients with early diffuse cutaneous systemic sclerosis, DCSSC, primarily for skin involvement. Efficacy. Evidence shows moderate efficacy in improving skin thickening but limited impact on internal organ involvement. Considerations. Monitoring for hepatic and pulmonary toxicity is crucial given the potential adverse effects. SURE-2, mycophenolate mofetil, MF. Use. MMF is commonly used for managing interstitial lung disease, ILD, associated with systemic sclerosis. Efficacy. It has shown benefits in stabilizing or improving lung function with a relatively better side effect profile compared to cyclophosphamide. Considerations. It is often preferred due to its favorable tolerability over the long term. 3. Azathioprine. Use. Azathioprine is sometimes used for systemic sclerosis-related ILD, particularly as a maintenance therapy following cyclophosphamide. Efficacy. Its efficacy is generally considered lower than MMF, and it is often reserved for patients who cannot tolerate other treatments. Considerations. Regular monitoring for bone marrow suppression and liver toxicity is required. 4. Cyclophosphamide. Use. Although it can be considered a cytotoxic agent, cyclophosphamide is used as a potent immunosuppressive treatment for severe scleroderma, especially for rapidly progressive ILD and severe skin involvement. Cyclophosphamide has been shown to improve lung function and skin thickening, but is typically used as a short-term option due to its toxicity. Considerations. Risks include significant immunosuppression, hemorrhagic cystitis, and long-term malignancy risk. 5. Leflunomide. Use. Leflunomide is sometimes considered for patients with systemic sclerosis, particularly those with arthritis symptoms or skin involvement. Efficacy. There is limited evidence supporting its use, so it is not commonly the first-line TSDMARD for scleroderma. Considerations. Similar to other DMARDs, monitoring for hepatotoxicity and blood count suppression is essential. Conclusion. The use of TSD-MARDs in systemic sclerosis is generally adjunctive, often combined with other therapeutic strategies like immunosuppressive agents, biologics, or antifibrotic therapies, depending on the disease manifestation. The decision to use these medications should be tailored to the individual patient's needs, balancing efficacy and potential side effects, and always in a multidisciplinary context. For systemic sclerosis, it's essential to focus on organ-specific management and early intervention to prevent irreversible damage. Biologic disease-modifying antirheumatic drugs, BDMARDs, are increasingly being explored in the management of systemic sclerosis, scleroderma, although their role remains less defined compared to other autoimmune diseases like rheumatoid arthritis or lupus. Systemic sclerosis is a complex disease characterized by fibrosis, vasculopathy, and immune dysregulation, which makes targeting the disease with biologics challenging. However, there has been growing interest in certain biologics for specific manifestations of the disease. Here's an overview. 1. Rituximab, anti-CD20 monoclonal antibody. Use. Rituximab, which targets B cells, is one of the most studied biologics in systemic sclerosis. It is used primarily for systemic sclerosis-related interstitial lung disease, SSc-ILD, and sometimes for severe skin involvement. Efficacy. Clinical studies suggest that rituximab can stabilize or improve lung function in SSc-ILD patients and may help with skin thickening. It is considered particularly useful for patients who are refractory to other treatments like mycophenolate mofetil or cyclophosphamide. Considerations. Rituximab is generally well tolerated but carries the usual risks associated with B-cell depletion, including infections and infusion reactions. HAMR-2, tocilizumab, anti-IL-6 receptor monoclonal antibody. Use. Tocilizumab targets the IL-6 receptor and has been investigated for both skin and lung involvement in systemic sclerosis. Efficacy. In the Fascinate and Focused trials, tocilizumab showed potential benefits in stabilizing lung function and possibly improving skin fibrosis in systemic sclerosis patients, particularly those with early progressive disease. However, its efficacy in reducing skin thickening was more modest. Considerations. As with other biologics, the risk of infection, including serious infections, needs to be considered when using tocilizumab. 3. Belimumab, anti-BLyS monoclonal antibody. Use. Belimumab, which targets B lymphocyte stimulator BLS, is approved for systemic lupus erythematosus and has been explored in systemic sclerosis, especially for patients with overlapping features of lupus or with high B cell activity. Efficacy. Evidence for belimumab in systemic sclerosis is still emerging, and its role remains investigational. Some case reports suggest benefits in controlling systemic manifestations in selected patients, but robust clinical trial data are lacking. Considerations like rituximab, belimumab may help in cases where B-cell-driven pathology is prominent. 4. Abatacept, CTLA-4Ig, T-cell co-stimulation blocker. Use. Abatacept, which inhibits T-cell activation, has been investigated in systemic sclerosis, particularly for its potential role in skin involvement and joint disease. Efficacy. Preliminary data suggest that abatacept may have a modest effect on skin fibrosis, but larger studies are needed to confirm these findings. It has shown some promise in managing systemic sclerosis-related arthritis. Considerations. As with other biologics, infection risk and careful patient selection are critical. 5. Anti-fibrotic biologics. New biologic agents targeting fibrotic pathways are being developed, though none have been definitively approved for systemic sclerosis yet. Anti-TGF-β therapies and other anti-fibrotic biologics are being studied in clinical trials. Conclusion. The role of biologic DMARDs in systemic sclerosis is still evolving, with the most evidence supporting the use of rituximab and tocilizumab, particularly in patients with interstitial lung disease and severe progressive skin involvement. However, their use is generally considered off-label, and decisions to employ biologics should be made in a multidisciplinary setting, considering the potential benefits and risks for each patient. Given the complexity of systemic sclerosis, biologics are often used in conjunction with other treatments, e.g., immunosuppressants, antifibrotics, rather than as standalone therapies. Clinical trials continue to explore these options, aiming to better define their role in disease management. Antifibrotic drugs are gaining attention in the management of systemic sclerosis, scleroderma, particularly because fibrosis is a hallmark feature of the disease, affecting skin, lungs, and other organs. These drugs aim to target the fibrotic pathways that lead to the excessive deposition of collagen and other extracellular matrix proteins. Here are some key antifibrotic agents being explored for systemic sclerosis. 1. Nintedanib, tyrosine kinase inhibitor. Mechanism of action. Nintedanib is a tyrosine kinase inhibitor that blocks several growth factor receptors involved in fibrosis, including vascular endothelial growth factor, VEGF, platelet-derived growth factor, PDGF, and fibroblast growth factor, FGF receptors. By inhibiting these pathways, nintedanib reduces fibroblast proliferation and extracellular matrix deposition. Use in systemic sclerosis. Nintedanib is the first antifibrotic drug approved by the FDA and EMA for systemic sclerosis-associated interstitial lung disease, SSc-ILD, based on the results of the SENSES trial. Efficacy. The SENSES trial demonstrated that nintedanib significantly slowed the rate of decline in forced vital capacity, FVC, in patients with SSc-ILD, indicating a benefit in preserving lung function. However, its impact on skin fibrosis and other systemic features of scleroderma remains less clear. Side effects. The most common side effects include gastrointestinal issues, particularly diarrhea, and hepatic enzyme elevation. Close monitoring is needed during treatment. R2. Pirfenidone, antifibrotic and anti-inflammatory agent. Mechanism of action. Pirfenidone has antifibrotic, anti-inflammatory, and antioxidant properties. It reduces the production of profibrotic cytokines, including TGF-beta, transforming growth factor beta, which is a key driver of fibrosis in systemic sclerosis. Use in systemic sclerosis, pirfenidone is approved for idiopathic pulmonary fibrosis, IPF, another fibrotic lung disease, and is being investigated for SSc-ILD in clinical trials. It has shown potential in stabilizing lung function in scleroderma-related lung fibrosis. Efficacy. Preliminary data suggests that pirfenidone may reduce the progression of lung fibrosis in systemic sclerosis, though larger trials are needed to confirm its efficacy. Side effects. Common side effects include gastrointestinal symptoms, skin rashes, and photosensitivity. Monitoring for liver function abnormalities is also necessary. Hash 3. For Fresolimumab, anti-TGF-beta monoclonal antibody. Mechanism of action. Fresolimumab is a monoclonal antibody that targets TGF-beta, a central mediator of fibrosis in systemic sclerosis. TGF-beta promotes fibroblast activation and collagen deposition, and inhibiting this pathway can reduce fibrosis. Use in systemic sclerosis. Fresolimumab has been tested in early phase clinical trials for systemic sclerosis. It showed promise in reducing skin fibrosis in a small group of patients. Efficacy. While early studies are promising, larger trials are needed to confirm its effectiveness in systemic sclerosis. Its impact on internal organ fibrosis, such as in the lungs, is still under investigation. Side effects. The side effect profile of fresolimumab in systemic sclerosis is not fully established, but potential risks may include immunosuppression-related complications and infusion reactions. 4. Other emerging antifibrotic therapies. Losartan and other angiotensin II receptor blockers. ARBs like losartan have shown potential antifibrotic effects in systemic sclerosis, particularly in the skin and kidneys. These drugs inhibit the renin-angiotensin system, which can contribute to fibrosis. Studies suggest some benefit in reducing skin fibrosis, but these drugs are not specifically approved for this indication. Endothelin receptor antagonists. Drugs like bosentan, ambrisentan, and macitentan target the endothelin pathway, which is involved in vasoconstriction and fibrosis. While these agents are primarily used for pulmonary arterial hypertension, PAH, and systemic sclerosis, they may have secondary antifibrotic effects. FG-3D19 pamrevlumab. This drug targets connective tissue growth factor, CTGF, which plays a role in fibrosis. FG-3D19 is being studied for idiopathic pulmonary fibrosis, IPF, and other fibrotic diseases, including systemic sclerosis. Early trials are ongoing. Anti-IL-13 therapy. IL-13 is a cytokine involved in fibrosis. Agents targeting IL-13 are under investigation for fibrotic diseases, including systemic sclerosis, with some early promise. Number 5, combination therapy. Because fibrosis in systemic sclerosis is a multifactorial process, there is growing interest in combination therapy approaches. For example, combining antifibrotic drugs with immunosuppressive agents or biologics may offer a more comprehensive strategy to halt or reverse fibrosis in systemic sclerosis. Conclusion. Antifibrotic drugs are an exciting area of research in systemic sclerosis, with nintedanib being the most advanced in terms of clinical use, particularly for lung involvement. Other antifibrotic agents like pirfenidone and fresolimumab are still under investigation, but hold promise for targeting different aspects of the fibrotic process in systemic sclerosis. Given the complex and systemic nature of the disease, the future likely lies in combination therapies that address both immune dysregulation and fibrosis simultaneously. The use of antifibrotic drugs in systemic sclerosis, scleroderma, is a rapidly evolving field, and guidelines are emerging as more clinical data becomes available. Currently, the most defined guidelines focus on managing systemic sclerosis-associated interstitial lung disease, SSc-ILD, where antifibrotic agents like nintedanib have been integrated into treatment algorithms. Below are the general principles and specific guidelines for the use of antifibrotic drugs in systemic sclerosis. General principles for antifibrotic use in scleroderma. 1. Patient selection. Antifibrotic drugs are primarily indicated for patients with evidence of progressive fibrosis, especially in the lungs, e.g., SSc-ILD. Early identification of patients at high risk for progression is crucial. This includes assessing lung function, e.g., forced vital capacity, FVC, Imaging, e.g., high resolution computed tomography, HRCT for fibrosis and disease duration. Multidisciplinary team MDT discussions involving rheumatologists, pulmonologists, and other specialists are essential for deciding on antifibrotic therapy. 2. Combination therapy. Antifibrotic drugs are often used in combination with immunosuppressive therapy, particularly in SSc-ILD. For example, combining nintedanib with mycophenolate mofetil, MMF, or cyclophosphamide may provide a more comprehensive treatment approach by targeting both inflammation and fibrosis. 3. Monitoring and safety. Regular monitoring for drug-related adverse effects is critical, including liver function tests, gastrointestinal symptom management, and routine lung function testing. Patient education on potential side effects, particularly gastrointestinal symptoms with drugs like nintedanib, is essential for ensuring adherence and early management of complications. 4. Long-term management. Scleroderma is a chronic disease, and long-term treatment with antifibrotic agents may be necessary to prevent disease progression. Close follow-up to assess both efficacy, e.g., stabilization of lung function, reduction in skin fibrosis, and safety, e.g., managing side effects, should be part of routine care. Specific guidelines for antifibrotic drugs. 1. Nintedanib, FDA approved for SSc-ILD. Nintedanib is indicated for patients with systemic sclerosis-associated interstitial lung disease, SSc-ILD, particularly those with evidence of progressive lung fibrosis. Initiation. Nintedanib should be considered in patients with declining lung function, e.g., decreasing FVC or progressive fibrosis on imaging, HRCT. Early initiation may be beneficial in preventing further decline in lung function. Dosing. The standard dose is 150 milligrams orally twice daily. Combination therapy. Nintedanib can be used in combination with immunosuppressants like mycophenolate mofetil, MMF. The Senses trial allowed for concomitant immunosuppressive therapy, which is common in clinical practice. Monitoring. Regular liver function tests due to the risk of hepatotoxicity. Gastrointestinal side effects, particularly diarrhea, are common, so patients should be managed proactively with antidiarrheal agents and dietary modifications. Duration. Long-term use is generally recommended as long as the patient shows clinical benefit and can tolerate the drug. 2. Pirfenidone, investigational for SSc-ILD. Indication. Pirfenidone is not yet approved for systemic sclerosis, but clinical trials and off-label use may be considered in patients with progressive ILD who are not candidates for nintedanib or other therapies. Initiation. Pirfenidone may be initiated in patients with progressive lung fibrosis, particularly when other antifibrotic options are not available or tolerated. Dosing. The typical dose for idiopathic pulmonary fibrosis, IPF, is 2,403 milligrams per day, divided into 3 doses. This dosing can be extrapolated to scleroderma patients, though dose adjustments may be necessary based on tolerability. Monitoring. Liver function tests should be performed regularly. Skin reactions and gastrointestinal symptoms, e.g., nausea, anorexia, need to be monitored and managed appropriately. Duration. As with nintedanib, long-term therapy may be needed to maintain benefits. 3. Other antifibrotic agents, e.g., frisolimumab, FG-30119, pamrevlumab. Indication. These agents are still in the investigational stage and are not yet recommended in standard guidelines for systemic sclerosis. They may be considered in clinical trial settings or for compassionate use in highly selected patients with severe progressive fibrosis who have failed other therapies. Initiation and monitoring. If used, these therapies should be initiated and monitored in specialized centers with expertise in systemic sclerosis and access to clinical trial protocols. Guideline recommendations from key societies. EULAR guidelines, European League Against Rheumatism. EULAR guidelines for systemic sclerosis recommend considering antifibrotic therapy, e.g., nintedanib, in patients with SSc-ILD, particularly those with evidence of progression despite immunosuppressive therapy. Combination therapy with immunosuppressants, e.g., MMF, is endorsed. Regular monitoring and a personalized approach to treatment based on the extent of lung involvement and overall disease severity are emphasized. ACR guidelines. American College of Rheumatology. The ACR recommends antifibrotic therapy in SSc-ILD patients, particularly those with progressive disease on standard immunosuppressive therapy. Nintedanib is specifically mentioned as a treatment option for ILD in systemic sclerosis. Close collaboration between rheumatologists and pulmonologists is advised for the management of SSC ILD patients on antifibrotic drugs. Conclusion: antifibrotic drugs, particularly nintedanib, have become a standard part of the management of systemic sclerosis associated interstitial lung disease, with guidelines recommending their use in patients with progressive fibrosis. Combination therapy with immunosuppressants, careful patient selection, and regular monitoring for side effects are essential components of therapy. As new antifibrotic agents are developed and studied, guidelines will continue to evolve, offering more options for managing the fibrotic complications of systemic sclerosis. Targeted synthetic disease modifying anti-rheumatic drugs, SMARDs, are a class of medications that specifically target molecular pathways involved in autoimmune diseases. While TSD-MARDs are well established in conditions like rheumatoid arthritis and psoriatic arthritis, their use in systemic sclerosis, scleroderma, is still under investigation, and there are no TSD-MARDs currently approved specifically for systemic sclerosis. However, some TSD-MARDs have been explored in systemic sclerosis for their potential to modulate key pathways involved in fibrosis, immune activation, and vascular damage. Here is a summary of the most relevant TSD-MARDs in the context of systemic sclerosis. Here's one: JAK inhibitors, Janus kinase inhibitors. Mechanism of action: JAK inhibitors such as tofacitinib, baricitinib, and upadacitinib target the JAK-STAT signaling pathway, which is involved in the immune response and inflammatory processes. By inhibiting this pathway, these drugs reduce cytokine signaling, which can modulate immune activity and potentially fibrosis. Use in systemic sclerosis. Evidence: JAK inhibitors are being investigated for their potential to manage the immune and fibrotic aspects of systemic sclerosis, particularly skin fibrosis. Preclinical studies and early phase clinical trials suggest that JAK inhibition may reduce skin thickness and inflammation in scleroderma patients. Applications: while not yet standard of care, JAK inhibitors could be considered in clinical trials or for off-label use in systemic sclerosis patients with prominent inflammatory and fibrotic features, especially those refractory to other treatments. Considerations: the safety profile of JAK inhibitors includes risks of infections, e.g., herpes zoster, thrombosis, and hematologic abnormalities, which require careful monitoring in systemic sclerosis patients. 2. Apremilast phosphodiesterase 4 inhibitor. Mechanism of action: apremilast inhibits phosphodiesterase 4, PDE4, leading to increased cyclic AMP levels and reduced production of pro-inflammatory cytokines such as TNF-α, IL-17, and IL-23. Use in systemic sclerosis. Evidence: apremilast has shown some potential in reducing inflammation and fibrosis in preclinical models of systemic sclerosis, but clinical trial data are limited. Its role remains investigational, particularly for patients with early inflammatory skin disease or arthritis associated with systemic sclerosis. Applications: apremilast may be considered off-label for selected patients with systemic sclerosis, especially those with overlap syndromes involving psoriasis or psoriatic arthritis. Considerations: apremilast is generally well tolerated but may cause gastrointestinal side effects such as diarrhea and nausea, which can be particularly challenging in scleroderma patients. 3. TGF-beta inhibitors. Mechanism of action: TGF-beta inhibitors target the transforming growth factor beta pathway, which is a key driver of fibrosis in systemic sclerosis. Agents that inhibit TGF-beta signaling could theoretically reduce fibrosis in the skin, lungs, and other organs. Uh, Use in systemic sclerosis. Evidence: TGF-beta pathway inhibitors such as pirfenidone and investigational agents like frizolimumab are being studied for their antifibrotic effects in systemic sclerosis. While not classified as TSD-MARDs, they represent a targeted approach to modulating fibrosis, similar to how TSD-MARDs work by targeting specific molecular pathways. Applications: These agents are currently in clinical trials, and their use in systemic sclerosis remains experimental. Considerations. Safety profiles for TGF-depot inhibitors are still being established, with potential risks including immunosuppression and increased infection risk. 4. Other targeted agents. Fingolimod and sphingosine 1-phosphate S1P receptor modulators. These agents target the S1P receptor pathway, which is involved in lymphocyte trafficking and has implications in immune modulation and fibrosis. Fingolimod has been explored in systemic sclerosis for its potential to modulate immune cell migration and reduce fibrosis, although data are limited. Considerations. Fingolimod's safety concerns include bradycardia, macular edema, and infection risk, which require close monitoring in systemic sclerosis patients. Challenges and future directions. Limited data. While TSD-MARDs are promising, robust clinical trial data in systemic sclerosis are still lacking. Most studies are small or early phase, and more research is needed to establish the safety and efficacy of these drugs in this population. Off-label use. Given the lack of approved TSD-MARDs for systemic sclerosis, any use of these agents is currently off-label and should be considered only in specialized centers with experience in systemic sclerosis management and clinical trials. Combination therapy. In systemic sclerosis, a combination of antifibrotic, immunosuppressive, and targeted therapies may offer the best approach. TSMARDs could be integrated into these strategies to address specific manifestations of the disease. Conclusion. The role of TSMARDs in systemic sclerosis is still emerging, with JAK inhibitors and other targeted therapies showing potential in managing fibrosis and immune dysregulation. However, their use is currently investigational, and more clinical trials are needed to define their place in therapy. For now, TSMARDs may be considered on a case-by-case basis, particularly in patients with refractory disease or in clinical trial settings.